So, doctor, really important. A lot of people are looking at this accelerated TMS, getting it done faster. How fast can TMS be done? I don't want to come for 8 weeks, 6 weeks, whatever that protocol may be. We have heard of the same protocols. Can you give me, number one, information on what Saint protocol is, and then we'll get into it a little bit more from there?
Sure. It's very exciting. You know, the work that Nolan Williams and Ellie Cole are doing is very exciting. It's a new way of doing TMS. You know, SAINT stands for Stanford Accelerated Intelligent Neuromodulation Therapy. And what they do is something that's unusual. First, it's more treatment and more frequent treatment. So what they do is they do intermittent theta burst stimulation, which is one of the FDA cleared treatments. And instead of doing 600 pulses, which typically was the original FDA approved number of pulses, they do 1,800 pulses, which is a 10-minute protocol, and they do 10 of them in a day.
Yeah.
So it'll be a 10-minute protocol, and then they rest for 50 minutes.
Okay.
Do another 10-minute protocol and rest for 50 minutes. Do another 10-minute protocol and rest until you've done 10 a day. And then you do that for 5 days a week.
Okay.
So in essence, that is 50 treatments. But if you look at it, it's really like 150 treatments. Right. Compared to the 3-minute, 600 pulse protocol that got the original FDA clearance for intermittent theta burst. So it's a lot of treatment and it's a lot of pulses. But what was really exciting about this was they were having close to 80% remission rates.
Okay.
Now, one of the things that was found at a month out, they lost some of that response and remission rates. The remission rates kind of went down to about 46%, and response rates about 2/3. Response is 50% reduction of the scales that they were using.
Okay.
So it was great that we got all that, all those people, or Dr. Williams and Dr. Cole got all those people well. We don't know necessarily whether it's going to hold.
Yes.
How well it's going to hold over the weeks and months later. Now, not only did they do the frequency was increased and the number of pulses was increased, they did some other things. They did functional scanning with a functional MRI. And what they did was they did a pinpointing of the area which had what's called the most negative correlation, which is called anti-correlation, between what was cold in the thinking part of the brain, the dorsolateral frontal cortex, which was what was hot in the anterior cingulate cortex. And they chose that spot. And they did it with neuronavigation. And they also had a special way that they adjusted their TMS system so that it gave a 90% motor threshold power in that location.
Okay.
So there was many different changes that occurred. So after that, there was a company called Magnus Medical, that is doing the current studies and have put forward to the FDA for approval, and they got the approval last summer. However, there are no systems out yet that you can purchase for this, just to let you know. And most insurers don't cover it.
Nope.
Actually, all insurers don't cover it.
Yeah.
So you have to pay out of pocket for that whole amount of treatment, which could be, tens of thousands of dollars, if you wanted to do that, treatment.
Just not to interrupt you, but so the treatment is simply 1 week.
It's a 1-week treatment, a highly intensive. It's a 10-hour treatment, so it's 10 hours a day,
right?
5 days. So where Magnus Med is going is looking to put it in inpatient, at least initially, so that they would be able to get all the staff, have the observation, and be able to do it, and may potentially take over for what ECT is doing. that
That's
if you have a
actually really
suicidally depressed,
fascinating and exciting.
yeah,
There could be a ton there, but it's just time, something time will tell, right?
yeah, it's too early right now to say that do you need all the bells and whistles? Do you need that neuronavigation?
Mm-hmm.
Do you need that functional scanning? Do you need that level of frequency? Is it just the frequency that you need? So there are a lot of people around the world that are doing accelerated treatments
Okay.
that aren't synced, where
Okay.
there are modifications of what
Uh-huh.
sync do. They may do scalp measurements to locate exactly where to do the treatment, but they'll do the same frequency, but maybe they'll do 10 a day, maybe they only do 5 a day.
Well, that's the other one I've heard, right? The 5 a day for 2 weeks instead of the 1 week. What you're saying is that's not saint. It's just a variation of it.
It's
Right?
a variation of an accelerated protocol.
Got you. Okay.
So now there are studies that have looked at using scalp locations and 5 a day for a week that showed it was effective.
Okay.
Andy Kozel, his group in Florida, did that work. But again, it is too early, and we don't know necessarily whether it holds.
Right.
And one of the things that we know about ECT is it's fast, it's furious, but it's highly short term. That it usually causes people have recurrences and often need maintenance in order to maintain the wellness. We don't know necessarily whether the fast and furious of the SAINT protocol is going to lead to persistent effects over time.
Right.
I mean, those of us who do a lot of longer term TMS see good durability, see our patients, 70% of our patients still doing well at the end of the year.
Right.
We don't know if that the fast and furious is going to work as well, or whether maybe the way it's going to eventually roll out is, let's do the fast and furious and then add some maintenance afterwards to keep people well. That may be another way of doing this, but again, it's very early. We're sort of in the adolescence of TMS.
Yes.
We're just starting to learn about this, and that's also what I'm trying to do with the foundation: increase academic rigor in the field of TMS. Let's get more studies. Let's fund more studies so that we can answer those very important questions.
That's actually interesting. Doing the fast and the furious, and then maybe in the taper, giving them 2 weeks of 1 a day. What is that going to do? Again, something time will tell, and just learning, right, and studying and coming back with the facts and the knowledge and going from there. But at the end of the day, you're helping people out. You're
helping people out. We're learning more. So the unanswered questions about this are: are accelerated protocols better than the longer term 1 a day protocols? That's one. Number two, what the duration is of the effect, and is it shorter duration or not? Do you need to do functional scanning on patients, meaning doing MRI scans and looking at the exact locations? Or as my good friend, colleague, Tony Barker, who's a friend of mine who invented TMS, said that TMS is much more broad spectrum. It's wider. It's not focal. So do you really need to do all that focused neuronavigation and scanning or not?
Is it a pinpoint or is it a shotgun blast? Right. Do you know the answer to that one, or do you have an opinion on that one?
I think that my opinion about this is that it is broad spectrum. I think that we have to see whether, and there really hasn't been a lot of head-to-head of let's do the neuronavigation versus the non-neuronavigation and see which works better. I think some of the studies that have looked at just doing what's termed the 5 centimeter rule versus neuronavigation showed that the neuronavigation worked better than the 5 centimeter rule. However, when we're teaching at the Clinical TMS Society in our Pulses course is a modified BMF3 method that was shown to be very similar to neuronavigation, so without the money, having the cost of a MRI and all the navigation equipment. So the jury's still out on that. So
But
if
at the
you're
end of the
not doing
day,
neuronavigation right now, you're still doing the standard of care that
at the end of the
we
day,
have.
what I'm hearing, Doc, is you need money for your foundation so that you can look at all these wonderful things and advance TMS.
I mean, that's what we're going to be trying to do. That's what we're doing with our foundation. We're trying to increase scholarship. We're trying to increase travel. We're also giving travel awards to young researchers so they can actually present their research throughout the world. That's one of the initiatives that we have. We're also, there's a journal of the Clinical TMS Society that's going to be starting.
Okay.
And we want that journal to be open source. And so one of the other initiatives would be for us to fund the open source so that anybody could pick out the articles without having to pay a subscription fee.
Yeah.
So that's another initiative that we're really trying to do. So we have Bob Sammons, who's a good friend of mine. He has, unfortunately, acute myelogenous leukemia. And we named a scholarship in his honor. He's been very involved with the Clinical TMS Society and our foundation. And we want to fund clinical research in psychiatry with his fund. So if you want to say, hey, I want to learn about OCD, I want to learn about anxiety disorders, post-traumatic stress disorder, let's fund some research in that. That would be the Bob Sammons Fund. Okay. That you could donate towards. So these are all great works that we're really trying to do. And we have the leaders in the field of TMS are part of the foundation. Like Mark George, who's the father of clinical TMS, is a member of our board, and he's on the clinic expansion committee, really wanting to put these clinics, these free clinics, all over the world. And so if you want to say, hey, TMS really benefited me, I want to donate to this, go on to facttms.org.
There it is.
And donate to whatever initiative you feel speaks to your heart.
If you guys found the information in this video helpful, do yourself a favor. Click on this video right here.
Seriously, click on this video. Click on this video.